The major problem when imaging the heart is that it's actually hidden behind the ribs, the lung, and the sternum. And actually there are only quite small little windows where you can appreciate the heart. There are windows which we define as the parasternal window, the apical window, the subcostal window, the right parasternal window, and also the suprasternal window, which is basically right up here. Now, of course, the size of these windows vary greatly, and frequently you will not be able to image all patients from all windows with equal image quality. In this lecture, we'll talk about the parasternal window. Usually you will image either in the third or in the fourth intercostal space. Let's take a look at how we can actually find this window. It's actually quite easy to find the parasternal window. The parasternal window is on the left side of the sternum, and what you should do is you should start at the top and just move the transducer down until you see an image. In his case, the parasternal window is very far cranial. In other words, we're somewhere in the third intercostal space. In some patients, however, you'll have to move further down into the third or even fourth intercostal space. A few specific points. The parasternal approach doesn't work all the time. It's somewhere in the range of 50 to 75% of patients who get optimal image quality. If you know how to image, it's probably still more towards 80 or even 85%, I would say. Use the left lateral position because here it's very important. Otherwise, you will have less good image quality practically in most patients. But this does not mean that you cannot get the parasternal window even if the patient is lying on his back. And finally, always try to stay as close as possible to the sternum because there you usually have less lung tissue. Now let's take a look at the first view, the so-called parasternal long axis orientation. Now this is a view where you have a longitudinal view of the heart. Here you would image the heart in a way where you would transverse both the basal portions, so the cranial portion of the heart, the ventricles, and also behind the atria. In the following demonstration, you're going to see which structures we see and how we can actually acquire such a view. Let's identify the structures you can see in a parasternal long axis view in our model. Now, the image quality here is really superb, so you can see even very detailed and small structures. What do we have here? Well, we have the aortic valve. This is the right coronary cusp, and this could be either the acoronary or the left coronary cusp. It depends very much on how we angulate the transducer. We have the ascending aorta here. This is the right ventricle, the myocardium. Observe that we can even see the speckled appearance here in the myocardium. Now, this is not a diseased left ventricle, it's a normal ventricle. But with the high resolution we have in the modern machines, we can even see the orthogonal cut of the myocardial fibers. So don't mistake this for some kind of a pathology. We have the mitral valve here with the anterior leaflet and the posterior leaflet. Look what happens if I move the transducer back and forth a little bit. I tilt the transducer now more cranially or more caudally, and what you will nicely see is the papillary muscle and the chordae as they insert into the mitral valve. So a wonderful way of scanning the mitral valve. We'll talk about that in the chapter on mitral valve pathologies. We have the posterior leaflet right here, which is shorter, the posterolateral wall, and the coronary sinus, which is this small little dot right here. Behind the left atrium, we have the descending aorta. And if you play around a little bit with the transducer, you can even see the ostium of the right coronary artery right here as it exits from the coronary sinus. And there are even more structures you can see in a parasternal long axis view. You can see the pulmonary artery right here. And if you tilt the transducer a little bit, you will actually see the pulmonary artery right here with the pulmonary valve. So this structure here is the pulmonary artery, and you can even see the pulmonic veins as they enter the left atrium. You can tilt both to the left shoulder, then you will get the left pulmonary veins, and more caudally to the right, and you'll get the right pulmonary veins entering the left atrium. Of course, the key structures you will see are the left ventricle, the right ventricle, the aorta, the aortic valve, the mitral valve, and the left atrium. But if you want to become a true expert, there's a lot more you can see if you use small little variations of the parasternal long axis view. We'll show you in this following simulation. If you want to become a master, there are additional views you can get from the classic parasternal long axis view that will show you additional structures. First of all, you can tilt the transducer a little bit more to the right or to the left. So let's see what happens if you tilt the transducer a little bit more to the left. If you do that, all of a sudden you will actually see the pulmonary veins entering the left atrium right here. And if you move the other direction, you will nicely see the right pulmonary vein enter into the left atrium. So you will not be able to see these structures all the time, but if they are dilated or if you have flow there, then you know exactly which structure you're looking at. An additional important structure is the pulmonary artery, which you will see very cranial here, close to the ascending aorta, and also on top of basically the left atrium. If you tilt the transducer a little bit more cranial, you will all of a sudden see the pulmonary artery and the pulmonary valve. If you tilt the transducer to the other direction, more caudally, you will see the tricuspid valve and a so-called long axis view of the right ventricle. Both of these views are very important if you want to assess right heart pathologies. Of course, you will not always get spectacular images like the one I'm showing you right here, but you should aim to get a view where the septum is more or less in direct continuation with the aorta. In other words, where you do not have an angle here. This would be the optimal view. What affects this angle? Well, basically, where you image the parasternal long axis view on the chest, more cranial or more caudal. Here is what happens if you place the transducer very cranial. And here, what happens if you have the transducer maybe in the fourth or even fifth intercostal space. You see that the angle gets longer and also the position of the septum. Here it's going more and more towards a parallel orientation to the imaging plane. Now, if you want to perform M mode and if you want to measure the ventricle here, this is definitely not the right view to use. And many people always say this is not a good view. I'm a little bit in opposition to that because there's many other things you can do aside from measuring. If you want to look at the mitral valve or if you want to look at the septum and if you get the best image quality here, use this view. It's just as good. Of course, if you perform measurements, you have to be aware that you're going to cut through the ventricle oblique and that the measurements will be off. For those of you who took the Echo Bachelor class, this is just a repetition, but it's a very important fact. It shows you what happens if you don't have the correct rotation if you want to perform a longitudinal view. The view here at the bottom is the correct view. You have the full length of the ascending aorta in your view, and you have the ventricle quite large. Actually, you don't see myocardium here in this region. If you either rotate counterclockwise or clockwise, you'll have a different view. You will not see the entire ascending aorta. The aortic valve or the aortic root will look almost round, and you will have myocardium right here. So if you have these views, you just need to rotate either clockwise or counterclockwise to get to the correct view. When I perform a classic parasternal long axis view, I actually don't only perform one view, but I perform two views. One where I place the transducer more cranial, and one which I place in the normal position where you get the best image quality. Why do I do this? Because if you have a more cranial position, you will also be able to see more of the ascending aorta right here. You will hear much more about this issue when it comes to the pathologies of the aorta, because there we will also discuss how important it is to detect aneurysms or dissections, and frequently you will have dissections and dilatation of the aorta in regions which are very far cranial and which you will not see if you perform a classic normal parasternal long axis view. Now let's take a look at which pathologies or which features you're supposed to look at when you perform a plaques view. Basically, if you get a plaques view, you've almost performed a complete exam already, because here you see very many things. You're able to look at the size and the function of the heart. You can estimate the size of the left atrium, look at the size of the right ventricle right here as well, and as I already mentioned, especially if you use the more cranial view, also the ascending aorta. You can detect pericardial effusion, which might be located right here. You can see the outflow tract very nicely. You're very close actually to the transducer, so it gives you the possibility to detect pathologies such as an LVOT obstruction, as in this example where we have a hypertrophic cardiomyopathy. Of course, we can see the flow across the aortic and the mitral valve as well, so you'll detect all the pathologies that are visible here. You will be able to look at stenosis of the mitral valve, regurgitation of the mitral valve. You can look at how well the aortic valve opens, whether or not it's calcified, and whether or not, for example, regurgitation or stenosis is present. So actually, with one parasternal view, you probably already have 80% of the exam done. In the classic parasternal long axis view, you're going to cut through the left heart part. If you do this, you'll get a view which looks something like this here. You have the right ventricle, the right atrium, the coronary sinus, and the IVC. Let's take a look in the following demonstration of how you can get such a view and more details of what you can do with it. The parasternal long axis view through the right ventricle is such an important view, and actually I think that it should be a part of every exam. And it's very easy to get. You start out from a parasternal long axis view, and all you need to do is tilt the transducer down. This is the motion you perform to get the long axis view. What are the anatomical structures that you can identify? This is the right ventricle. This is the right atrium. The thin structure is the coronary sinus here, and this is the IVC that you can follow relatively far distal as it enters here into the right atrium. Now, sometimes it would make sense to move the transducer down one intercostal space, and you can get an even better view of the right ventricle. What you see here now is the anterior leaflet and the posterior leaflet. So this is the view where you can clearly identify which leaflets of the tricuspid valve you're seeing. This concludes the long axis views that we can acquire from a parasternal window. Next on our list will be the short axis view.